Thanks very much, Dan. Thanks, John. Certainly an honor to be chosen to participate in the SAGES University Master's Program series. I appreciate the invitation from the program chair, from the president, from Dan Jones, the people who've put this together this week, Ted Truss and Rob Finelli. And I'll try and stay on target and on time with the topic of colorectal surgery. Firstly, SAGES obviously being a minimally invasive surgery society, I'm really not going to discuss open surgery. However, suffice to say that the methods are the same and the end results have to be the same. So we need to achieve the aims of laparoscopic surgery, conferring these various benefits on our patients, but we need to make no compromise over the type of resection we do in open surgery. So the principles that I'll talk about are really the same regardless of the access approach, whether it's through an incision. The videos I'll show will be laparoscopic, but it could be any type of minimally invasive approach to achieve these goals. But towards that end, I was asked to review the clinically relevant anatomy and physiology of the colon, a little bit about preoperative evaluation and operative indications, and then techniques, and perhaps more than results, just focusing on some of the challenges and conundrums and results specific to some of those areas. So why is it important to know your anatomy? This is a 1991 laparoscopic colectomy being done with the only instrument available at the time, a cautery, and somebody who really, I think, should know their anatomy. Buzzing along, just to put things in perspective, the patient's pelvis is towards the right of the screen, and the head is here, and the abdominal wall is here, and a little bleeding. Go back with the cautery. Turned out it was the iliac artery. So the line of Tolt may sometimes stray, and your instruments may stray, and that's why it's very important to know anatomy. You don't want to be in a situation where suddenly you think something is a little retroperitoneal bleeding, and it turns out it's a hole in the iliac artery. So suffice to say, anatomy is key. I won't play that again. I don't think I'm going to play that again if I can advance. So, starting with the colonic anatomy, the name of the colon in Greek means to retard, and really the colon is meant as kind of a brake, storage organ to slow things down before reaching the rectum, where the stool can be evacuated at a socially appropriate time and place. The colon's variable in length, and you can see the different dimensions. I'm not going to read them, but it can be substantially augmented by dilatation. So the diameter increases and it can be stored more and more. Anybody wanting to delve more into it, the reference for the anatomy is our second edition of the ASCRS textbook of colorectal surgery. This is put out by the American Society of Colorectal Surgeons, and the anatomy is in more detail there. But the salient anatomy for today is as depicted. The colon has taeniae, and there are various types, the libera, the mesocolica, and the omontalis. They merge at the rectosigmoid junction, and that's one of the ways we can tell rectosigmoid junction. Why is that important if you're a surgeon and not an anatomist? Because when you're operating for diverticulitis, you must resect all sigmoid, you must create your anastomosis to the cephalad aspect of the rectum or some point distal to that. So when you're deciding where the colon ends and the rectum begins, it's important to see that convergence of the taeniae, that the haustral outpouchings are gone. There are no haustral folds. And the appendices epiplocae are also gone. Those structures are part of the colon and not of the rectum, an important differentiator. The cecum is largely invested in peritoneum. The ileum terminates usually in the posteromedial aspect, although there is some variability. And when you're doing endoscopy, I'm sure Dr. Ponsky will go into this about the internal view, but the external view is easier to recognize, this slit-like opening from the outside. Again, the ileocecal valve is part of this brake, part of this two-retard mechanism to slow things down in the colon. And when I come to the physiology, you'll remember from medical school why. So from the cecum, the ascending colon goes up, lateral to the psoas muscle, anterior to the iliacus, quadratus lumborum, and the lower pole of the right kidney. Again, important to recognize these things when you're thinking about, is that the ureter? No, it's the psoas tendon. You've got to understand where you are. Once the peritoneum is not present, there's an areolar tissue, which is known as the line of Tolt, and that's where in that other video the dissection should have been, although not as deep. And this is from an embryologic fusion process where this is a coalescence of the mesentery to the posterior parietal peritoneum. And those of you who were here yesterday in this room when we did the colorectal mastery, co-chaired by Tonya Young-Fadek, Hermann Kessler presented a beautiful video in which the oncologic principles based on this embryologic fusion plane in the ascending colon become very, very apparent to do a central mesocolic ligation with a complete mesocolic excision. The transverse colon is difficult for oncology, and Hermann explained that yesterday, but surgically it also can be difficult because it's tethered by two flexures. The nadir, the lowest point, could reach into the pelvis, certainly the hypogastrium, but even in patients with colonic inertia into the pelvis. There's a greater omentum that's fused on the anterosuperior aspects. If you're removing a transverse colon cancer, you have to remove that aspect, and some would argue even for an extended right hemicolectomy, it has to be removed. Then the splenic flexure can be loosely attached, or it can be virtually in the chest, high up, attached to the spleen, and one has to be very careful in mobilizing the splenic flexure not to try to pull things down, but to work up to, which is one of the many advantages of laparoscopy, being able to work up to the splenic flexure rather than like a laparotomy, dragging it down. The descending colon, then again, like the ascending, isn't completely invested, but it's covered anteriorly and laterally, and then posteriorly again rests against the left kidney, the quadratus lumborum, and the transverse abdominis. It's narrower, and it's a bit more dorsal than is the right colon. The right colon, again, the cecum can distend much more than can the sigmoid colon. The sigmoid colon is supposed to be an omega loop. Sometimes it's a bit straighter, and sometimes it's very redundant, and it can dip into the pelvis. It can go up to the hepatic flexure, but the sigmoid colon has the longest, floppiest mesentery, this mesosigmoid, which is really an inverted V shape, and why volvulus is most common in that area, because it is the longest, it is potentially the most redundant. One of the key things in performing a sigmoid colectomy is to understand, like that video just showed, what lies beneath. And what lies beneath is going to be the left ureter, as well as, of course, the iliac vessels. Proceeding further down, there's the rectosigmoid junction, again, where you have the convergence of the teniae, obliteration of the haustral folds, and absence of appendices epiplocae. That's usually somewhere below the sacral promontory. The amount actually varies to some degree. Very important to recognize this point. And we do this both anatomically from the outside, but also endoscopically inside. And that's why for colorectal surgery, as I'll show you later, patients are always in the modified lithotomy position in stirrups. So we have transanal access, and one of the main reasons to perform a bowel prep, although that's beyond the scope of the lecture, one of the main reasons is not necessarily to do with infection, but to allow intraoperative endoscopy. And when you're operating and you need to see where the rectosigmoid junction is, you can see it, and it's generally 15 centimeters above the dentate line. Now, the arterial blood supply is very important. The colon has its blood supply from two vessels, the superior mesenteric, which in turn gives off ileocolic right colic, as shown here. Superior mesenteric, you have ileocolic vessel, you have right colic. You may have a high takeoff of both branches. Important to recognize the anatomy. So when you're operating on the colon, you've got to very carefully see where those vessels are, not just do en-bloc ligation, because for a proper oncologic operation, you're going to need to be high up on the vessels and make sure you're not taking the wrong vessel, the SMA. The IMA, there's a bit of debate about whether there's a lower rate of anastomotic leak if you do a selective ligation of the left colic, which includes then also the terminal sigmoidal branches. So you would essentially take the vessels here and here, leaving this left colic, versus doing a high ligation. And I think, from my point of view, the better mobilization, the ability to have more length generally comes from the high ligation, but there are some people who believe that it's a higher leak rate. The SMA comes from behind the aorta, behind the superior border of the pancreas. Important to recognize that, and important when you're performing a right hemicolectomy to understand that there are variations, that the middle colic may be absent. That makes an important distinction on what type of anastomotic blood flow you're going to have. So you've got to be able to recognize where's this SMA, the right colic and the ileocolic vessels. The middle colic is the highest of the three colic branches of the SMA. It also comes up close to the inferior border of the pancreas, and the right branch goes to the right transverse colon. So if you're performing an extended right or lesions at the hepatic flexure, the right branch is certainly going. On the other hand, if you're going to perform an extended left for some reason, you might take the left branch. But there can be a high common takeoff, and it's important to be able to recognize that. But again, there are variations, and up to a fifth of cases, depending on series, it's actually absent or it's just accessory in about 10%. It also can be the main blood supply to the splenic flexure. So you have to, again, sometimes stop. You may on occasion want to gently occlude a vessel with a bulldog clamp or gently with a clamp and see what happens. You may use perfusion assessment. There are different ways to look at it if you have any doubts about blood supply. But it's important to understand what vessels an individual patient has. Moving around to the left, when we're performing rectal cancer surgery, which again is something I'm not going to be discussing rectal resections and pouches in this lecture, but important to understand even for a sigmoid colectomy, where's the inferior mesenteric artery? Comes from the left anterior surface of the aorta, above the bifurcation, usually at the level of L2-3, and then as I showed in the diagram, once it crosses the left common iliac, it's called the superior hemorrhoidal or superior rectal artery, and the left colic, as the diagram also showed, bifurcates into the ascending branch up the left, and then the so-called terminal sigmoidal branches. The sigmoidal branches form arcades and anastomose again with the superior rectal. The marginal artery itself terminates with the arcade of the sigmoid, so the rectum doesn't have a marginal artery. By the time the sigmoid colon ends, you have the superior rectal artery, and that's it. And that artery continues to descend down to about S3 and then to the posterior aspect of the rectum. Venous drainage parallels again, so you've got the right colic and ileocolic, and then coming up the inferior mesenteric, which again you can variably ligate as high ligation at the inferior border of the pancreas and duodenum, or you can ligate with selective preservation of the left, depending upon your choice, but that's not good. But it's important to know what the choices are for ligation. For oncology, you obviously want to be able to excise at least the NCCN minimum number of 12 nodes, but ideally a lot more, and you should be getting 20 plus nodes in most of these specimens. And you can see why the level of ligation makes a difference. You'd like to get not just the N1, but N2 and even N3 nodes if possible. That's why, again, for a right colectomy, you'd like to ligate here and not something like the right colic and then separately down here ileocolic, because you can see all those nodes being left behind. You'd like to do a complete mesocolic excision with a triangle of tissue coming out, so you'd basically go from here with the right branch of the middle colic out to here and down, take about a couple of centimeters of ileum. It used to be said 10 centimeters. I'm not sure that's necessarily always the case, but that enables a complete mesocolic excision. If we look at it somewhat schematically instead, we're going to trace up when we're performing a left hemicolectomy. Again, high ligation would be performed here, high ligation would be performed here, but if you elect to instead preserve the left colic, you're going to ligate here and here. Laparoscopically, inferior mesenteric vein is coming in here, just past, as it shows, the fold of the duodenum, the inferior border of the pancreas shown here in the photo and here. Important to recognize those structures. Innervation of the colon is extrinsic and intrinsic. So extrinsic is both sympathetic and parasympathetic. And here's where after lunch people really start drowsing and falling asleep. But the main neurotransmitters include acetylcholine and substance P. The parasympathetics come proximally from the posterior division of the vagus nerve, and they follow the arteries. Where we tend to look the most is at the sacral promontory, where we see this typical wishbone configuration of the nerves right at the sacral promontory. The distal colon gets parasympathetic from S2 to 4, The third sacral is the most dominant. It is a mixed nerve, which is why when we do sacral neuromodulation, we go for S3 because it's both sensory and motor. The nervi argentes traverse deep to the peritoneum. They join the inferior hypogastric plexus on the anterolateral pelvic wall, which is why you have to be careful when performing a TME not to injure those structures, particularly in the lower third of the rectum. Separately, there's the preganglionic parasympathetic fibers with synapse in the bowel wall. So there's the submucosal Meissner's plexus and the subserosal Auerbach's plexus. What do? The sympathetics inhibit peristalsis, again, to retard from the Greek name, prevent epithelial secretion, and reduce splanchnic blood flow in that kind of fight or flight response, if you will. They also supply excitation to the sphincter muscles, which is the ileocecal valve is a sphincter muscle, and then, of course, the internal anal sphincter. So when we treat with nitric oxide inhibitors for anal fissure, that's essentially what we're doing is blocking them. The primary sympathetic neurotransmitter is norepinephrine. So there's something called the enteric nervous system, which is kind of separate than the central nervous system. So the CNS moderates the nerves I've told you, but then there's the enteric nervous system as well. These two interplay, but basically everything is conducted along the two plexi, Auerbach's plexus and Meissner's plexus. You have one between the muscular layers and one in the submucosal layer that are monitoring and modulating these impulses as they come down. So acetylcholine becomes excitatory, and as I mentioned, nitric oxide for fissures, for example, and ATP are on the inhibitory side. So this is how you can kind of, if you will, paralyze or do a medical sphincterotomy to try and treat an anal fissure. It makes sense if you can think about the pharmacology and pharmacopathology behind it. But the enteric nervous system, which are the mu2 receptors in the small bowel, they primarily control peristalsis, and when you look at using an agent, a mu2 inhibitor, to reduce post-op ileus, that's how it works, is by blocking these receptors so that the patient's not going to get a post-op ileus when opioids bind to those same receptors. The extrinsic nervous system are the reflexes, so sympathetic nerves inhibit peristalsis, and parasympathetic nerves promote motility. So it's a push-pull kind of a mechanism, if you will. On top of all those nerves, then the antegrade and retrograde balance has to do with the radius of the colonic segment, the consistency of the stool and pressure gradients. So why does the colon retard? Because it's salvaging nutrients through fermentation, and that takes time. So the colon is acting both as a storage agent, but also as a fermentation vat, if you will. There are over 400 species of bacteria. Most of them are obligate anaerobes. So again, this stuff actually makes sense when you think about what antibiotics do you want to use for coverage. Complex carbohydrates, short-chain fatty acids, and butyrate. Butyrate is what supplies 70 to 90% of the energy requirements for the colonocyte while they're doing their jobs with the obligate bacteria. Colonic transfer of water, that's the other thing the colon does. So number one is ferment, and number two is it draws in water, generally about 1.5 liters to 2 liters a day, which is why when you take out the colon and construct an ileostomy, people will typically have about 1 to 1.2 liters per day in the stoma because they're no longer able to absorb this fluid through the colon. But most of the water is reclaimed, leaving about 100 to 150 ml of stool, which is laden with these 400 plus species of bacteria. But the colon can actually absorb a lot more, and that's mediated by aldosterone and short-chain fatty acids with somatostatin. Interestingly, the colon can prevent hyponatremia, even with a very, very small daily sodium intake, but the absence of a colon obviously encourages dehydration, hyponatremia. Again, think of the ostomate. Think of the patient who comes in with 2 liters a day stoma output. They're dehydrated, and they may well have hyponatremia. So when you put all of this together, you think, well, I've got to operate on the patient for the colon. What do I need to know? Now, in part, that depends upon the patient, as well as the patient's colon, obviously. Comorbidities, same as any surgery you're doing. Is the patient a smoker? Do they drink excessive amount of alcohol? What other medical conditions they have? So these are the general things you'd think of for any operation. But then there's things that perhaps are slightly more unique to colon surgery. We talk about inflammatory bowel disease patients. Are they taking steroids? Are they taking anti-TNF agents and biologics that may impair healing of anastomoses? These things are key, and we've got to think of them. There's a lot in the literature to suggest that biologics taken within 1 to 2 months prior to an operation should mitigate a stoma because of impaired healing for up to 1 to 2 months. Steroids, again, if the patient's taking 20 a day, you may be fine. If the patient's If the patient's taking 60 a day, you may think twice about doing an anastomosis that's unprotected. Then when we start looking at rectal cancer, which again isn't specifically going to be covered in the talk, but it's important to realize patients may have neoadjuvant. A lot of patients get neoadjuvant therapy. What does that do for healing? So where do you time performing the surgery relative to neoadjuvant therapy? And do you now add a diversion because of it? And then again, other things here that are important. Key thing with colon, look at the pathology. Is it really ulcerative colitis or is it Crohn's? Is it really an invasive cancer or is it a polyp with high-grade dysplasia? So I think it's important to review the pathology as well as any hereditary symptoms. If you're going to take care of a 35-year-old patient who has 2 cancers in the colon and it turns out that they've got a hereditary cancer syndrome, you shouldn't be doing 2 segmental resections. That's going to be a total colectomy and an ileorectal or maybe a J-pouch. So think about what the history is. Physical exam, has the patient had a prior stoma, for example? If you're marking for an operative stoma, think about scars. You've got to mark for stomas away from bony prominences and away from scars. Obesity, certainly we see that everywhere. And then all of the routine things that we might get. Again, in our IBD patients, we think a lot about albumin and prealbumin. We do standard imaging with chest x-ray just for anesthesia if it's indicated, but in patients with colon cancer, certainly the gold standard for staging would be a CT of the chest, abdomen, and pelvis. Many people these days come with a PET CT to assess for any metastatic disease, and that impacts the timing of surgery. For our IBD patients, they're all going to get images of the small intestine in one way or another, and of the colon. So they'd get either CT or MR enterography to have a look for any ileitis that's going on. They would have an endoscopy, and they may also have a gastrograph and enema to look for a variety of left-sided pathologies. Certainly for pelvic issues, MRI is the way to go. Definitely rectal cancer protocol for rectal cancer, but also for things like presacral cysts and sarcomas, the MRI is much more accurate than is the CAT scan. Patients with complex fistulae, there may be some value to doing a perineogram or a fistulogram, although they're not terribly useful. They can be of some value. Again, the MRI really does tend to be more sensitive and more specific. If it's a patient you're seeing for constipation, you would do what's called motility imaging. So you want to make sure the problem is limited to the colon if you're considering a colectomy, and that's obviously a colonic transit to see that the colon's slow, but it's also helpful to do gastric emptying and small bowel transit to ensure that it's not a panenteric inertia, because if it is, taking out the patient's colon isn't going to help them with their inertia at all because they still have a gastric emptying delay and small bowel delay. More common than constipation, obviously, is operating for other things, such as polyps. And one of the things that's become very important as we do all of these procedures laparoscopically is ink marking, because in the open scenario, you could usually feel where the lesion is, not true laparoscopically, particularly with malignant polyps, polyps with invasive cancer, non-endoscopically retrievable polyps. So I think ink marking is key, and I always recommend ink marking at a few points on different walls, because you may not be sure which is the mesenteric margin, and if you end up inking only the mesenteric margin, you won't see it laparoscopically. So, we put out a little study on this last year just because there's a lot of variability in marking, and we thought maybe there should be some standardization, especially as patients may come to you already marked from another lesion. You need to be able to differentiate when you're operating with tattooing. So let's get to some specifics. Right hemicolectomy, why would you do it? Well, you might do it for cancer or some other type of neoplasm, a carcinoid, an appendiceal tumor. You might do it for another neoplasm that's not malignant, like an endoscopically irretrievable polyp. Very commonly, we'll do it for Crohn's disease, terminal ileal or ileocecal Crohn's disease. Rarely in this country, more so in Asia, right-sided diverticulitis, and then there's a host of other things that can occur. I mentioned before, if you're going to do right hemicolectomy, usually you'll take 6 to 10 centimeters of the terminal ileum and the proximal transverse colon, not always, but usually. And that includes, as I showed earlier, right branch of the middle calyx. This is why it's important to think about this. If you're going to go to an extended right and you're going to anastomose over in the area of the descending colon, you're going to obviously also take the left branch of the middle colic artery, and that's appropriate for tumors somewhere between the hepatic flexure and the middle colic vessels. Caveat here, if a tumor is a little bit to the right of the hepatic flexure towards the mid-transverse colon, I don't think a transverse colon resection is a good operation. I think it's hard to get all the appropriate lymph nodes out. The blood supply can be questionable for the reasons I showed earlier, and I think you're better to do an extended right, or depending on the position of the tumor, potentially an extended left. I mentioned earlier mechanical bowel preparation for a right colon in particular is controversial. But if no other reason, it can be very helpful to allow laparoscopic palpation with clamps and intraoperative endoscopy. Patient's going to be in stirrups. You can do intraoperative endoscopy. Just be sure you have a non-crushing atraumatic clamp proximal to whatever level you need to scope before you perform any intraoperative endoscopy. If appropriate, patients should be marked for stomas. If appropriate, like terminal ileal Crohn's disease with a phlegmon, cystoscopy and stents are a good precautionary measure. Skip criteria for antibiotics and DVT prophylaxis for everyone. Positioning in order to have that access, and again, these are photos from a book that Jim Fleshman and I did from the Mastery series, getting the patient using gel pads, a beanbag. I always do what I call test drive the bed. So before we prep and drep the patient, after they're positioned with both arms at the side, the legs up in stirrups, we use a Lloyd Davis type of stirrup, minimum hip flexion to prevent having a problem when the instruments are rotated from the lower quadrant port and banging into the thigh. Minimal hip flexion, maybe 15 degrees. It allows us to perform endoscopy for all the reasons elucidated here. But once the patient's positioned and strapped and secured in place, anesthesiological lines, before prepping and draping, I'll always have the bed put in all the positions I'll use during surgery to ensure the patient isn't slipping or sliding. They have to be stabilized to the bed. And the time to ensure that is before you prep and drape, not after, when you're in the middle of the case and the patient's sliding. That's problematic. For right hemicolectomy, I tend to work through 3 ports. I like 10 or 12 ports because I can use the 10 millimeter bipolar energy device. I can move my 10 millimeter camera to any port. You can certainly use 5s if you prefer, but I can also put in the stapler for intracorporeal division or anastomosis if I like, and so I tend to use this through 3 ports. I start out with a Hassan technique for all cases, generally in the infraumbilical position. You can go lateral to medial, which happens to be my preference. I realize I'm in the minority, or you can go medial to lateral. Either way, you have to identify the duodenum, the head of the pancreas, and the ureter. It's good to know both techniques. In fact, it's mandatory to know both techniques because there are situations where you can't do one or the other for various reasons, or it's safer or easier to do one versus the other. But you know, if you're going medial to lateral, I think it can be very, very tough if you've got a thick Crohn's mesentery and it's easier to mobilize stuff medially so you can hold it up. On the other hand, if the patient's had a prior nephrectomy, some other problem, things are stuck laterally, it may be easiest to go medial. So depending on how you're working, certain facets are going to be the same, which is table positioning, and that is why you've got to test drive the bed once the patient is in it. In addition to looking at the duodenum and the head of the pancreas, the right ureter has to be identified. Very important to know this anatomy. It's at the pelvic brim as it crosses the iliac artery bifurcation. So you have to see that for a right. I know some people say it's not mandatory. I just leave it behind the fascia. I like to see it. I like to know where it is. I'm not going to go rooting around, but it'll be where it's supposed to be in virtually every case. Helpful, again, with the patient properly positioned to go head up to get the hepatic flexure and to come over the top of the pancreas and the duodenum. For vessel ligation, I always do it intracorporeally. I prefer energy devices. So score, see the root of the superior mesenteric, know where the superior mesenteric is, get to the apex of the ileocolic vessel and the right branch of the middle colic. Once all the mesentery is divided, I don't generally intracorporeally divide the bowel on a right because I've got concern that when I have two free-floating ends, I might end up with a 360-degree torsion on one of them that looks like it's not twisted. 180 you can usually tell, 360 you might not. Leaving the bowel in continuity, I'll deliver it through the umbilical site, usually 3 to 4 centimeters through wound protector. With the mesentery still intact, I know that the bowel is straight, and then I can go ahead and perform the division of the bowel and the anastomosis. So, problems you can get into, difficulty identifying the ileocolic, put traction on it, you'll see it. If the transverse colon doesn't easily reach prior to making the incision, or if you need to, you reinsufflate, just dissect further. Take more of the gastrocolic momentum. Some people will say to do a mini laparotomy. I think it's a much better idea to reinsufflate, laparoscopically go back in, and generally it's a matter of just dividing more momentum. If you need to take the left branch of the middle colic, then you need to take it. Again, my trick for preventing twisting is to maintain orientation and, of course, to reinsufflate and have a look. I don't close the mesentery. So just a brief glimpse of what this would look like for laparosection. 3 ports, one in the left upper quadrant and one in the left lower quadrant, both placed after after putting in a Hassan in the infraumbilical region, visualizing the right ureter. Important, the 3 key structures as the line of Tolt is mobilized would be the right ureter, the head of the pancreas, and the duodenum. You want to see all 3 of these structures every time to know that they're safely out of the way as you're working. Here's the sweep of the duodenum. Here's some nice thick mesentery with fat wrapping from Crohn's. With Crohn's disease, there's no reason to go up and perform a high ligation. I think you're just asking for trouble with a big, thick, friable mesentery trying to intracorporeally ligate near the superior mesenterics. And I would deliberately stay down distal near the bowel. That gives me plenty of latitude if I need to resect further up, if I get some bleeding or a hematoma, because you can see how thick this mesentery is. I will use this instrument 2 or 3 times or more, not at the same spot, but kind of stagger it to make a longer seal. But you have to be prepared to suture, because if you've got any problem here with bleeding, with this kind of a thick mesentery, you've got to be able to go after it. So again, no high ligation unless there's a cancer in the face of Crohn's disease, but that's generally not the case. The umbilical incision is usually lengthened, about 3, sometimes 4 centimeters. If there's a huge phlegmon, it may need to be larger. Then everything is extracorporealized. So the important thing here is to make sure you go further on the transverse colon than you think you need to go, because it's always somehow less coming out the tractor than you'd like. So you make a very conscious effort. With Crohn's, we don't use microscopic margins, we use gross margins, and there's plenty of studies showing that there's no increase in recurrence if the microscopic margins are involved, as long as the gross margins were free of disease. So resect and perform an anastomosis, and I think in the interest of time, I'll show you one little thing that I do here, which is when the anastomosis is performed as a side-to-side, I try to get rid of the little mesenteric corners. Rather than having a rhomboid closure, I didn't show it there, but I will resect the corners before closing it, so I have one straight closure across the top. Left-sided resection, again, very similar reasons. Of course, much more diverticulitis, which isn't on the right, but short of those. The inflammation on the left would be diverticulitis, whereas on the right it was Crohn's disease. Splenic flexure tumors, kind of like hepatic flexure tumors, you're going to do an extended resection. I'm not a fan of splenic flexure resections, so I would go ahead and do generally an extended left, or again, an extended right and a subtotal if necessary. But I think an isolated splenic flexure resection is generally not a good idea. You should know these things in advance. You should know from your scanning for the most part. You could always be surprised, but endeavor to know what's going on. Diverticulitis, probably the most common reason for resection. Used to be thought if patients were under 50, they'd get a resection, multiple attacks, they'd get a resection. Not true. What is true if the patient's immunosuppressed, you have an oddball situation where a patient travels frequently to remote places, but it's far less set in stone than it used to be. Diverticulae are false outpatchings rather than true diverticulae, generally in the sigmoid colon, but they certainly can be pancolonic. We've evolved to a very individualized, tailored approach based upon the patient. There are certain relatively sure indications listed here, but most of them are really just patient choice made with the surgeon, with the family. Why would you do a sigmoid colectomy? You know, patients had lots of admissions, it's crippling their life, they're constantly on antibiotics, fine. Abscess that's been drained, recurred, drained again, fair enough. Colovesical fistula, even if it can't be endoscopically or image-wise proven, with symptoms suspected, as well as some of the advanced Hinchey stages, and these topics were covered yesterday, so I'm not going to go into them again. They're covered beautifully in 30-minute lectures. I think you have access to those. Again, patients are going to be in the modified Lloyd-Davies position. Difference from right and left. On the left side of resections, we irrigate the rectum to try to limit to some degree the contamination in that area even after bowel prep, but same thing, both arms at the side. In the case of diverticulitis, patients are marked both sides. Generally the left in case it's a in case it's a colostomy, and the right in case it's an anastomosis with a loop ileostomy. Again, Hassan technique. You can put, if it's an obese patient or high splenic flexure or big uterus, you may have a reason to put another port here in the left lower quadrant, but otherwise it's the mirror image of what I showed earlier for right iliac fossa and right upper quadrant with the Hassan in the midline. You can again go lateral to medial or medial to lateral. My preference, again, I like to go lateral to medial. I know that's the minority, but I also know that I need to know, as you should, how to do both approaches, because one, it's not always that one size fits all. I think that you have to know your endpoints, and your endpoints on the left are a long line of Tolt, including the splenic flexure if the anastomosis is going to be below the sacral promontory. That's key. If you don't take the splenic flexure, you may potentially have tension on your anastomosis. So mobilizing from lateral attachments, you have to make sure you don't, as I showed in that video, injure the iliac artery. You've got to know the position of the ureter. Splenic flexure, like hepatic flexure, a little bit of head up helps. Patient tilt to the right helps. You've done a test drive of the bed to be sure. Divide the gastrocolic ligament and get in the lesser sacs. You surround the splenic flexure. You've come up from the left side. You've come across middle, so you're not putting traction on the spleen to try to avoid splenic capsular lacerations. Vascular ligation, again, if you tent up, as shown in the photo, you can get to the root of the IMA if that's where you'd like to go. If you go to the root, you've got to be very careful not to injure the nerves we discussed, and that little wishbone I showed you earlier, you're going to have a very unhappy patient, particularly if it's for benign sigmoid disease. So if you see that window, you want to stay right, and I'll show this on the video, right on the back of the superior rectal vessels. You don't want to go straying towards the aorta and injure those nerves. Again, we discussed earlier, rectosigmoid junction. For diverticulitis, you've got to be right at the rectosigmoid junction. You do not want to leave any distal sigmoid. There's a study we published a couple of years ago. The only predictor of recurrence was an anastomosis to the distal sigmoid rather than to the rectum, fourfold higher. So you've got to know where the top of the rectum is. I also look endoscopically. Remember, patients prep, patients in stirrups. So I'll come up, non-crushing clamp, somewhere in the left colon, look up, be sure that what I think is 15, it looks like absence of haustral folds, absence of appendices epiplocae, confluence of teniae, but it's also 15 centimeters, and endoscopically there's not a single diverticulum. It's a nice, compliant rectum. That's important. Proximally, again, you've taken the splenic flexure most likely, and as we've shown earlier, whichever level you've divided, left colic sparing or else a high ligation, either way. Make sure for diverticulitis there's not going to be a diverticulum at the anastomosis. That's absolutely critical. You've got to be sure if you need to take more bowel proximally, take it. Distally, you've already ensured it endoscopically, but proximally, you've got your extracorporealized bowel. Be sure there's not a diverticulum. Go further back. The abdomen is reinsufflated. I like a 33 stapler. That emanated from the days when we used to do open surgery, when I'd put a TA30 distally, and then take a 33, so I had no dog ears. They were excised, but I like it. It's a wide anastomosis. If it's a distal anastomosis, make sure, in a female, obviously, the vagina is not incorporated. So I like to tell my residents everything's set up, everything's lined up. If you're doing perfusion assessment, you can do it before you fire the gun if you're using fluorescein to take a look, if you happen to do that. If not, gun's closed, you decide, and then, as I say, time to make the donuts. You fire your gun, and you want to see 2 very complete donuts, and I send all of them to pathology, individually labeled proximal and distal, because I don't want to discover later something was there we didn't know about. Same as right colon. What are the pitfalls? If you can't identify the inferior mesenteric, put traction on the mesosigmoid. If you have diverticular phlegmon or Crohn's phlegma and ureteric stents, to avoid tension on the anastomosis, high ligations, and splenic flexure mobilization. Very importantly, if it's a positive leak test, you should redo it. Suture reinforcement has a much higher leak rate. You can, and if it's a patient who you're planning to divert for other reasons, fair enough, redo, be sure there's no leak and divert, but simply suture reinforcing does have a much higher leak rate. Laparoscopic sigmoid colectomy, I'll show you a couple of key steps. The port positioning is mirror image to what I showed you earlier for the right colon. Is mirror image to what I showed you for the right colon. So here we're going to have 2 ports on the right, 1 on the left. Again, I like lateral to medial, personal preference. You can certainly do medial to lateral. Come up to the splenic flexure, and then surround the splenic flexure. So come in through the gastrocolic omentum and expose the splenic flexure, so rather than pulling it down to you, you're working up to it from both sides. And you can begin to see the spleen in the background there. This maneuver will give you the length you need for tension-free anastomosis at any level. Once the splenic flexure is down, you can lift up and you can see the iliac here, and you're going to come over the sacral promontory and create a window. So you want to be right under the superior rectal vessels. What you don't want to do is get in a plane where the nerves are going to get damaged. You want to stay hugging on the back of the superior rectal vessel, and you can see when you tent it out how nicely you can see that. Right on the back of the vessels, you're going to see your left ureter through the window, which if you're doing medial to lateral, you're going to see it first, obviously. Here's nerves right under here. We're not going to take the nerves. We're going to stay above them. So this isn't a super high ligation. It's above the left colic takeoff, but it's not going to damage the nerves. So important to stay on the back of the superior rectal vessels. Then there's going to be a little window, and then you're going to come to the vein, and you can see here's the duodenum, inferior border of pancreas, right here's pancreas, and left colic vein is probably going to be just in there. We may see it a little better. Then we go distally, just mobilize the very top of the rectum. There's no need to go further, but be sure under endoscopic guidance that we're transecting at the 15 centimeter level at the rectosigmoid junction, that we're not transecting to leave a bit of distal sigmoid. That's very, very important. You see the kind of mobilization and length we get when we do that. Then we can finish resecting the mesentery. You can do this inside as well if you like. I use a purse string clamp up top, make sure the bowel's free of diverticular disease, drop the anvil inside. Again, it's a 33. From below, couple everything, and I routinely endoscopically air test these anastomoses. I don't do just air testing, but I like to look at them too, so I can see the anastomosis and be sure that it's, you can see the endoscopic view, that I've got a hemostatic staple line as I'm working. Move this along. And here's, I mentioned this earlier, if you have a positive leak test, which is the Leahy Clinic was noted here in Boston, 8% of cases, suture repair alone, 12% leak rate, whereas if the patient was had the anastomosis redone, or they were diverted, which is obviously less satisfying for the patient, there were no leaks. So I think it's really important to make sure you've got a good anastomosis before you leave. Total colectomy, lots of reasons to do a total, slightly beyond the scope, but I want to just touch on this, some of the reasons you might do a subtotal colectomy: inflammatory bowel disease, pancolonic diverticulitis, slow transit constipation, GI bleeding. This is obviously more of an urgent setting, Clostridium difficile, colitis, C. diff colitis, all the reasons you might potentially do it. when you're doing a total, it's important to remember that you may, as in the case of C. diff or hemorrhage, have a very sick patient, hemodynamic instability, malnourished, maybe it's a patient with IBD. Just because you're doing a subtotal doesn't mean you do an ileorectal. You might do an ileostomy, or you might do an ileorectal with a loop ileostomy proximal, depending upon the patient. So again, like the other cases, make sure the patient is marked both sides in case you need to put an ileostomy one side or the other, same position, no different. Rectal irrigation. Now, so it's mirror image port placement. So we have both right and left side. So it's a total of 5 ports. These are the same maneuvers I showed earlier. In the interest of time, I'll skip through these. But one caveat, particularly if it's an IBD patient, you're thinking of a J pouch later, preserve the ileocolic so you can have optimal blood supply to a pouch or an ileorectal anastomosis at a later date. Also preserve IMA and superior rectal. Why? You don't want to violate the presacral space. It makes going back much more treacherous and a higher morbidity and more bleeding. So what I would always do is leave a bit of distal sigmoid. This is a case where I deliberately would leave distal sigmoid, so when I go back to the operating room, it's easier to find the stump and to deal with it. And I think the vessel ligation is best performed in a subtotal colectomy with a bipolar device. There's a publication we had in surgical endoscopy last year looking at patients who had laparoscopic total colectomies and found that patients basically had quicker operations, less blood loss, and shorter incisions with energy devices than they did with staplers, and less failures. Here's an example from an earlier case before I was using energy devices of a so-called vascular cartridge, and you can see something vascular making its way through the vascular cartridge quite nicely here. So I do tend to have a personal preference for energy sources, and this is one of the things that led to us deciding to do that little study. For the total colectomy, if you're going to do an anastomosis, my preference is if the colon's not massively dilated or the patient isn't massively obese, to bring everything out through the stoma site so that you don't have to make another incision. If you're not going to be making a stoma, I tend to use the umbilicus, and everything is otherwise exactly the same, including endoscopic visualization. It's rare, but if you're going to have tension on an ileorectal anastomosis, ligate the ileocolic. That's the one instance I do it. It's almost never necessary. If you take the leaf of the terminal ileum right up to the duodenum, pancreas, superior mesenteric vessels, you shouldn't. You can always mobilize the rectum a little, but again, I wouldn't advise that if you're doing a subtotal. But if you can do an anastomosis then and there, that's perfectly fine. You can gain additional distance from mobilizing rectum. I'd rather do that than ligate the ileocolic if possible. If you're going to ligate the ileocolic, do it before you create the anastomosis, because if it turns ischemic once you've done it, you've got to redo everything. So better to see what your reach is going to be, make a determination. If you need to ligate it, do it before you create the anastomosis. I'm not going to get into desmoids, and I already discussed a little bit of anastomoses. Just a quick glimpse here of a total colectomy. Again, it's kind of an amalgamation of some of the things you've seen already. It's the same principles to be able to use traction to find your vessels. Important to separately get the appendix up so that you don't inadvertently staple across it, things I've seen done. You want to mobilize up to, again, pancreas, duodenum, right here. These are all the landmarks you've got to see why the anatomy is so important. I would divide, depending what I'm doing, divide intracorporeally. I wouldn't necessarily waste a stapler and run up the money if I'm doing an ileorectal anastomosis. I would just as soon leave it intact, take it out, and put it in an anvil. But if I'm going to be doing an ileostomy, then yes, I would obviously divide intracorporeally. Here's an image with a little better anatomic discretion than the one I showed earlier. Same as before. Coming up, here's the left side, inferior mesenterics, looking at the presacral space, left ureter, all the anatomic landmarks you've got to see as you're working, and you don't need to go beyond the sacral promontory. And again, here we come up to the vein. Doesn't have to be a super high ligation in this particular case, but that traction is tremendously helpful, so I'll skip that. There are some other uses of laparoscopy, simple diversion. One little trick here, if you're going to make a stoma, you can generally do it through a loop ileostomy. You can generally do through 2 ports. one for the stoma site itself, the other port for the camera. Don't put the camera port next to the umbilicus. It's too close to the stoma site. You won't be able to see what you're doing. Put it midway between the xiphoid and the umbilicus. That's your camera, and then you can, with a grasping clamp, take a loop of ilium, pull it up, check orientation, and make your stoma. You can definitely spare ports in that one. Some of the challenges and conundrums in the last few minutes, this was covered to some degree yesterday with peritoneal lavage for Hinchey 3 diverticulitis, when to divert. Basically, the jury is still out, and to cut to the chase on this study in Annals, laparoscopic lavage, shorter operating time, shorter time in recovery room, shorter hospital stay, and not everybody even goes on in the Dalala trial to require a colectomy. But more recent, the exact opposite finding in this Scandinavian study, where in addition, they noted that 4 sigmoid cancers were missed by doing laparoscopic lavage. Now, I think that can be obviated by going in later and doing an endoscopy, but nonetheless, they had the opposite conclusion. So now we have the ladies' trial underway in Holland and elsewhere. You can see the study protocol's been published, and you can see the randomization schema. So the jury is still out. I don't know, out of curiosity in the audience, how many people here would do for Hinchey 3 laparoscopic lavage? 1. How many would do Hartmann's or another type of resection? Everyone else. Okay. When to divert, I mentioned earlier, immunosuppressed patients, malnourished patients, perhaps radiation. Obviously, during surgery, if you've got difficulties with anastomosis, patient's been hypotensive. What do we know for colon? From the Lacey trial, the Barcelona trial years ago, no difference globally, but actually for stage 3 patients, better recurrence-free survival laparoscopic than open. The Color trial, again, for colon cancer with over 1,200 patients. Again, a lot of short-term advantages and no adverse long-term advantages. In the COST trial in the US, again, I think everybody by now knows the data, but I wanted to put in a couple of slides here on data. No difference there either. And in the CLASSIC trial from the UK, followed up, there were no significant differences either in terms of recurrence. Crohn's disease, much better laparoscopically than open, less complications, no difference in disease recurrence. Decreased, which is different than a lot of other laparoscopic literature, decreased incisional hernia rates with laparoscopy. So you can see here in Patel's study, if you look at these various things, you can see the advantages of laparoscopy in some, others no statistical significance. How often is it actually employed? One of the recent studies showed that there's been an increase in the use of laparoscopy, more or less doubling in the US, and if you look at Marco Simonov's study, National Database Review, 380 hospitals decrease in open, increase in laparoscopy, but that's only through 2011. Hopefully the lines have now crossed. Looking at a database, and I think this was Ninwin's study for general surgery operations, and you get down nowhere near like bariatric, where they're virtually all done laparoscopically, or appendix, where they're virtually all done laparoscopically. Again, more or less 50% of colons and more like 20% of rectal resections. So in the remaining, I think, 3 minutes, I've got a couple of questions I'm going to put up there for you. Number 1, all of the anatomic features help determine the rectosigmoid junction except merging of Taenia coli, absence of haustra, absence of appendices epiplocae, location at aortic bifurcation. Do we do a show of hands or just read them off? 2, which is true for colonic physiology? Absence of a colon encourages dehydration, hyponatremia. Bicarb is absorbed by the colon during diarrhea in order to correct acidosis. Sympathetic nerves promote peristalsis, and parasympathetic inhibit motility, and colonic fermentation occurs via pancreatic enzymes. 3 is, which of the following is an indication for surgery in the setting of diverticular disease? Age under 50, more than 2 attacks, immunosuppression, or morbid obesity. 4, which of the following is the best method for treating an anastomosis after a positive air leak test? Repair, redo, reinforce, or divert. 5, which of the following is a predictor for recurrent diverticulitis after sigmoidectomy? Age, extent of disease, Hinchey score, or level of anastomosis. And 6, which of the following is not an advantage of the modified lithotomy position? Transanal endoscopic access, position for assistant, decreased perineal neuropathy, access for splenic flexure mobilization. Again, I think I stuck to my hour, just. I'd like to thank you very much.